Yes, sir.
Okay. So under uh, patients admitted to the ICU with tropical infections, usually the questions are asked in relation to approach to a patient with tropical infections, or they may ask a specific set of tropical infection and they may ask into clinical manifestations, diagnosis, and management. So in today's discussion, the predominant question that was asked was on severe malaria and approach. But for your exam purposes, I have also prepared points in relation to dengue, lepto, scrub, enteric fever, Zika, and Nipah. So I will not be discussing about these topics. I'll keep the slide for 5 seconds for each of these areas so that when you read through these recorded videos, it would be definitely beneficial. So when you are asked about these infections, it is always better to mention it under these subheadings: classification, etiology and pathogenesis, clinical manifestations and severity assessment, diagnosis, treatment, and related trials, if any. So coming to severe malaria, that is most commonly because of Plasmodium falciparum. So the classification as per the WHO comes as uncomplicated malaria versus severe malaria. Now, severe malaria is defined as any one of the above: impaired consciousness, presence of seizures, acidosis, acute kidney injury, severe anemia, pulmonary edema, ARDS, shock, jaundice, or eye parasitemia. So, if any of these features are there, then it comes as severe malaria. So, coming to the etiology and pathogenesis, I've made it very concise because in the exam you are only given 5 pages. So, if you see most of the notes or books in relation to the pathogenesis of malaria, that itself goes for 1.5 pages. So, from an exam perspective, that is not feasible. So, what I've written here can be made like a flowchart. So, coming to Plasmodium falciparum, the infected red blood cells express this uh, PFEMP1. So that leads to cytoadherence to the vascular endothelium, leading to microvascular sequestration of the RBCs in the brain, lung, kidney. So because of this, there is obstruction of the microcirculation, which leads to tissue hypoxia, which leads to lactic acidosis. Further, because of this inflammation occurring, there is release of cytokines which amplify this endothelial injury, and subsequent hemolysis occurs. This hemolysis contributes to anemia, and hypoglycemia occurs due to the parasite consumption, and if patients are initiated on quinine, that causes hyperinsulinemia and that can lead to hypoglycemia. So this is about the simplified version of pathogenesis. So coming to the clinical manifestation and severity assessment, high-grade fevers, rigors, and diaphoresis are there. Neurologically, they can present with coma or seizures. Respiratory, either ARDS or pulmonary edema can be there. Renal, they can present with acute tubular necrosis and eventually develop oliguria. Jaundice can be there because of hemolysis or because of hepatic injury itself. Hematologically, they can be severe anemia, and because of endothelial injury that occurs in the microcirculation, there can be activation of platelets leading to consumption, and eventually consumptive coagulopathy can lead to TAC. Severity markers that need to keep in mind is GCS less than 11 or more than 2 seizures in 24 hours, lactate more than 5, severe acidosis with creatinine more than 3, urine output less than 0.3 ml per kg per hour, hemoglobin less than 7 with presence of shock, or parasitemia more than 5% in low transmission areas or more than 10% in high transmission areas. Now, why this is very important is these all form the basis for your ICU admission. If these are there, you need to take that patient into your ICU. So diagnostic testing, we have peripheral blood smear, thick and thin films, which is the gold standard for diagnosis. It aids in species identification and parasite count. It is usually repeated every 12 to 24 hours if negative, but the suspicion remains. So rapid diagnostic tests that can be done are histidine-rich proteins, that is HRP2 or parasite LDH. So one thing you need to keep in mind is, if at all you're able to remember, well and good. PF, Plasmodium falciparum, histidine-rich protein 2 gene deletion usually leads to false negatives. Then PCRs, it is the most sensitive. So it can detect up to one parasite per microliter, but not widely available for urgent diagnosis. Then supportive labs, complete blood count, liver and renal functions, arterial blood gas, serum lactate, and blood glucose. So it needs to be checked hourly if quinine is used. So the treatment is intravenous artesunate 2.4 milligram per kg at 0, 12, and 24 hours, and then every 24 hours till orals are tolerated. Then you can step down to oral artemisinin therapy based combinations like artemether lumefantrine or artesunate amidaquine to complete 3 days. So the total duration they say is between 5 to 7 days, but just remember it as 7 days. So if artesunate is not available, then you can go with IV quinine, 10 milligram per kg infused over 4 hours every 8 hourly, plus doxycycline or clindamycin. With regard to pregnancy, artesunate is safe in all trimesters. Then supportive management, cautious fluid resuscitation, especially if presence of pulmonary edema is present. Transfuse blood cells if HB is less than 7. Treat seizures with benzodiazepines. RRT if AK is present, if indicated. Lung protection ventilation for ARDS. So the related trials were the Sequomat trial, which came in 2005. Artesunate reduced mortality by 35% compared to quinine in adults. So then you have the Aquamat trial where artesunate was superior to quinine in African children. So the main references are here. So for the rest of the diseases, I'll just go through it every 5 seconds to the next slide. So I'm not going to go in depth. Just for your revision, I thought these contents would be very helpful.
Sir, you are not audible, sir.
No, no, I'm not currently speaking. I'm just going
Okay.
through the slides. I'm not discussing this area. This
Okay,
is
okay,
just
sure.
for the candidates for their exam revision. With regard to scrub typhus, it is very, very important to know about this interest trial. Those from CMC Vellore would definitely know about it because this was the place where the study was done. So this was published in the NEJM and it is now considered as one of the main modalities of therapy. So you need to know about it. Okay, so now going to approach to tropical infections in ICU. So there are 6 important areas that you need to focus. One is the image that is within the first 5 to 10 minutes. Then syndromic split. It helps to drive the first test and empiricals. Then diagnostic window by the day of illness, severity assessment, empirical therapy and tropical infections, and platelet transfusion rule. So The initial step in an unstable febrile patient in the ICU, it is important to resuscitate and stabilize. That is, you need to take care of the airway, breathing, and circulation. Draw starter labs, that is complete blood count, LFT, RFT, VBG or ABG, lactate with coagulation parameters and glucose levels. So you need to send two blood cultures. So it is important to use PPE or isolation if viral outbreaks are being suspected, especially in like example in cases of Nipah during the first outbreak, there was not much awareness related to that. But during the second time the outbreak had happened in Calicut, so people were aware about it. And so once they were able to identify the symptoms and signs, then immediate communication was made through the hospital and isolation precautions were immediately implemented in the emergency department and in the ICUs. So it is very, very important for very high risk transmission and high fatality associated diseases, isolation precautions being taken seriously. So this component is not usually discussed in most of the tropical diseases, but it is very, very important to know about them. So coming to history and physical examination, with regard to history, it is always important to know about the history to endemic areas, activities like swimming, farming, animal contact, food habits, or insect bites. Then the incubation period. So compare the onset versus the likely infections. Then prophylaxis history, whether history of vaccinations against typhoid, yellow fever, or meningococcus has been taken, or chemoprophylaxis has been taken, especially related to malaria or leptospirosis. And see for any pattern of disease, like a syndromic presentation, like fever with thrombocytopenia, fever with rash, or fever with jaundice, renal involvement, or neurological, pulmonary, or GA syndromes. If any kind of pattern is there, then that will also be able to aid in your diagnosis. So, with regard to the incubation period and the syndromic presentation, usually if it is less than 2 weeks, the commonest organisms that infections you need to look into are malaria, dengue, rickettsial fevers, leptospirosis, typhoid, viral hemorrhagic fevers, diarrhea, arboviral encephalitis, and Zika virus. Whereas if it is 2 to 6 weeks, then it goes into a subacute phase. So malaria, typhoid, hepatitis A and E, amoebic liver abscess or leptospirosis needs to be considered. Whereas if it is more than 6 weeks, then malaria and TB need to be looked into. So the syndromic split, it helps in guiding the first test and the empirical therapy. So if at all there is fever and rash, the suspected infections are dengue, chikungunya, rickettsial infections, meningococcemia, viral hemorrhagic fevers. Whereas if there is jaundice with AK and pulmonary hemorrhage, leptospirosis is the top differential you need to keep in mind. Then if there is SR with ARDS or MODS, then scrub typhus is your high suspected DD. So if fever with jaundice alone is there, then you have a wide variety of differentials like viral hepatitis, leptospirosis, malaria, scrub typhus. Whereas if it is a hemorrhagic fever, it can be because of dengue, Ebola, yellow fever, malaria, and leptospirosis. Whereas if there is fever with CNS signs, then there can be viral encephalitis, cerebral malaria, leptospirosis, which can cause aseptic meningitis, typhoid meningitis, and scrub typhus related encephalitis. So diagnostic windows by the day of illness. So day 0 to 5, usually it is preferable to go with PCR testing. All right. So for malaria, you can go with thick and thin smears or rapid diagnostic testing. For dengue, you can go with NS1 NS1 PCR. For lepto, scrub, or Zika, you can go with PCR and NAT studies. The main reason why I'm emphasizing on PCR is in this period, the 0 to 5 days, serology testing is generally not advised because when the virus or the organism enters your body, the body's natural response is to attack it. So for that to attack and produce immunoglobulins, it takes some time. So usually only after 4 to 7 days is the time when you really get these evident immunoglobulins in your system. That is the immunoglobulin M and the immunoglobulin G. that is IgM and IgG. So the IgM levels that we normally look into will be apparently seen only after 5 to 7 days. And for leptospirosis infections, they say to test it after 7 to 10 days. So initially, when they present within 5 days of your fever, that is, the fever sets in within 5 days, serology testing most of the time would turn out to be negative. So in those kind of scenarios, PCRs are a better testing modality. So if it is more than 5 days, then you can go with serology testing. So another important thing is to know about this thing called PRNT, that is the plaque reduction neutralization test. Especially it was done mainly in patients with Zika. So many a times there can be co-infections which can be missed. So if you do this PRNT, it can help you identify and differentiate between Zika and dengue. So for typhoid, the gold standard is to go with blood cultures. And if there is prior antibiotic exposure, then you can go with bone marrow cultures if it is feasible. So severity assessment. So in the initial slides that I put, along with clinical manifestations, I had mentioned severity assessment. So severity assessment is mainly done to decide on ICU admission. So for malaria, GC is less than 11, lactate more than 5, parasitemia more than 5 to 10%, presence of shock, ARDS or AKI. Dengue, if there are warning signs, you admit, or there is severe dengue with plasma leak or shock, or ALT/AST more than thousands with severe bleeding. For lepto, bilirubin more than 10, creatinine more than 3, or PF ratio less than 200 with evidence of diffuse alveolar hemorrhage. For scrub, if there are features of encephalitis, myocarditis, ARDS, AKI, or jaundice. For typhoid, if there is shock, presence of a bowel perforation, massive GA bleed, encephalopathy, or there is an XDR risk. For Zika, if there is rapidly progressive GBS, encephalitis, or autonomic instability, another one thing that I missed here is Zika-related ITP is very common. So if patients present with very low platelets with evidence of bleed and background of Zika, they need ICU admission. So empirical therapy in tropical infections, doxycycline covers scrub and lepto, IV artesunate if severe malaria is possible, broad spectrum antibiotics for typhoid with shock or XDR suspicion. So you need to go with meropenem. If these XDR risk factors are not there, then ceftriaxone is sufficient. Then once you get the diagnostic testing done and you are able to identify an organism, then you can go with targeted therapy. Then supported bundles. For dengue, you go with precision fluids, blood and platelet transfusions when indicated. For lepto, early RRT and ventilation for DH. For scrub, you need to go with combination therapy, that is doxy and acipro, that is based on the interest trial. Then for typhoid, if there is presence of perforation or bleed, then you need to get a surgical consent. And for Zika, if there is presence of GBS, you need to go with IVAG. Even if there is presence of ITP, IVAG is the mainstay of treatment. So platelet transfusion rule, if it is less than platelets is less than 10,000 without bleeding, prophylactic transfusion is needed to prevent the risk of spontaneous life-threatening bleed. Active bleeding, CNS involvement, or invasive procedures, you need a higher threshold, around 20 to 50,000. In dengue, avoid routine prophylaxis, transfuse only if less than 10,000 or clinical bleeding is present. So quick lab clues. For malaria, you identify for parasites on smear. Then for dengue, if you see that there is a high hematocrit with a drop in platelets, then it goes more in favor of it. For leptospirosis, bilirubin disproportionate to the transaminitis. For scrub, presence of SR, hyponatremia, and thrombocytopenia with transaminitis. For typhoid, culture positivity with relative bradycardia, and for Zika, they may present with positive urine NAT up to 14 days, and they present with GBS commonly.